Chapter number 14. Childhood Glaucomas, Clinical Presentation. Page number 223. Development of anterior chamber angle. The aqueous outflow structures in the anterior chamber angle appear to arise from the mesenchymal mass of neural crest cell origin. The precise details of this development are not fully understood. Theories have included atrophy or resorption, that is, progressive disappearance of portions of fetal tissue, cleavage, that is, separation of two pre existing tissue layers due to differential growth rates, and rarefaction, that is, mechanical distension due to growth of anterior ocular segment. Subsequent work suggests that none of these concepts is completely correct. Anderson studied 40 healthy fetal and infant eyes by light and electron microscopy and found that the anterior surface of the iris at 5 months gestation inserts at the edge of the corneal endothelium, covering the cells that are destined to become trabecular meshwork. This appears to be what was called the fetal pectinate ligament, separating the corneoscleral meshwork primordium from the anterior chamber angle. Anderson observed a posterior repositioning of the anterior uveal structures in relation to the cornea and sclera in progressively older tissue specimens, presumably because of the differential growth rates. At both the insertion of the iris and ciliary body is near the level of the scleral spur, and the posterior migration of these structures continues for about the first year of life. There is some difference of interpretation regarding the innermost layer of the trabecular meshwork primordium, as it is uncovered by the posteriorly receding iris. Anderson thought that the smooth surface represents multilayered mesenchymal tissue, which begins to cavitate by the seventh fetal month. Others have suggested that a true endothelial layer covers the meshwork during gestation. Henson and Gendel observed that the anterior chamber angle portion of the endothelial layer begins to flatten with loss of clear cut cell borders by the seventh fetal month. During the final weeks of gestation and the first weeks after birth, the endothelial layer undergoes fenestration with migration of cells into the underlying uveal meshwork. Van Buskirk observed a similar endothelial layer and its progressive fenestration in macaque monkey eyes. He noticed that fenestration and gradual retraction of this tissue occurred in the third trimester and progressed in a posterior to anterior direction. Mac Minmin, however, in a scanning electron microscopic study of 32 human fetal eyes, found that the endothelial layer in the iridocorneal angle was perforated by discrete intercellular gaps by 12 to 14 weeks, and that the gaps between the inner uveal trabecular endothelial cells were sufficiently developed by 18 to 20 weeks to allow a route of communication between the fetal anterior chamber and primitive trabecular tissue. Chapter number 14. Childhood Glaucomas, Clinical Presentation. Page number 224, Figure 14.8. A concept of anterior chamber angle development. Insights show cross-sectional views of the chamber angle. Figure A. At 5 months gestation, a continuous layer of endothelium E creates a closed cavity of the anterior chamber, according to most studies, and the anterior surface of the iris I inserts in front of the primordial trabecular meshwork TM. Figure B. In the third trimester, the endothelial layer progressively disappears from the pupillary membrane PM and iris and cavitates over the anterior chamber angle ACA, possibly becoming incorporated in the trabecular meshwork. At the same time, the peripheral uveal tissue begins to slide posteriorly in relation to the chamber angle structures. Arrow. Figure C. Development of the trabecular lamellae and intertrabecular spaces begins in the inner posterior aspect of the primordial tissue and progresses toward the Schlemm canal SC and Schwalbe line SL. Figure G. The normal anterior chamber angle is not fully developed until 1 year of age.